You are standing in the ER and a patient walks in after a nasty bump to the head. They're chatting, answering your questions, and they honestly seem, completely fine.
Right, they look totally stable.
Yeah, exactly. But inside their skull, a hidden ticking time bomb is about to go off. Catching that invisible threat before the patient rapidly crashes is, well, it's the absolute ultimate test of a nurse's clinical judgment.
It really is. It changes so fast.
It does. Welcome to an episode of the Super Nurse podcast, created by Brooke Wallace. Now, while I am not Brooke, she's a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author. This entire episode is built directly from her bedside knowledge.
Yeah, we're using her actual notes in her teaching style today.
Exactly. Our goal today is to help nursing students and new nurses take what they learn in school and actually apply it in real patient care.
And before we get started, we want to invite you to subscribe and watch the video version of this conversation on YouTube. You can find the link in the description on our channel, which is called Super Nurse AI.
So our focus today is decoding traumatic brain injuries, or TBIs, in plain English.
Yes, moving way beyond basic textbook memorization.
Right. We want real-time pattern recognition so you know exactly what to look for at the bedside.
Because what clinical experience shows us is that TBIs are incredibly common. We're looking at roughly 2.5 million people sustaining TBIs annually.
That is a staggering number.
It really is. And about 85% of TBI-related deaths occur within just the first 2 weeks of the injury.
Wow. 2 weeks. And, when most people hear the term TBI, their brain immediately jumps to, massive motor vehicle accidents or extreme sport.
Right, the really dramatic stuff.
Exactly. But the number one cause of TBIs is actually falls, especially in the elderly population.
Yeah, and to understand how a seemingly stable patient can deteriorate so incredibly fast from a fall, we have to start with the physical environment of the brain itself.
So we need to separate the primary injury from the secondary injury?
Exactly. So when that fall occurs, we see the primary injury. This is the initial blunt or penetrating force.
Like the literal moment of impact.
Yeah, the skull hitting the pavement or penetrating trauma like a gunshot wound.
Mm-hmm.
The primary injury is done. It's happened.
There's nothing we can do to reverse that impact.
Exactly. So as bedside nurses, what we are actually battling is the secondary injury.
The secondary injury is the fallout. It's that reactive cascade that kicks in after the impact. Things like hypotension, hypoxia, ischemia, and massive cerebral edema.
Which is really just the medical term for brain swelling.
Right. And the reason that swelling is so deadly comes down to a core physiological concept called the Monroe-Kellie hypothesis.
Yeah, and if we translate that into plain English, your skull is basically a rigid, bony box.
It absolutely cannot expand.
Exactly. Inside that rigid vault, there are only three things.
Mm-hmm.
Brain tissue, blood, and cerebrospinal fluid, or CSF.
Just those three?
Just those three. Because the vault is a fixed size, if the volume of one of those things increases, say like a bleeding hematoma or swelling brain tissue, the volume of the other two must decrease to make room.
Right, they have to compensate.
Yeah, and if they can't decrease enough, the pressure inside the skull spikes exponentially.
I always think of the skull like a tightly packed, hard-shell suitcase.
Oh, that's a great way to look at it.
Right, like you have your clothes, your toiletries, your shoes. It is zipped up tight. If you try to shove an extra pair of boots in there, the suitcase doesn't stretch.
No, something inside is getting crushed.
Exactly. But wait, if my forearm swells up from an injury, it hurts, but it's not instantly lethal. Why is the brain so uniquely vulnerable to pressure compared to, a bruised arm?
Well, if your arm swells, the skin and muscle tissue can expand outward into the surrounding air.
Right, there's room.
Exactly. The skull absolutely cannot expand. Because of that rigid bony box, the swelling brain tissue has nowhere to go but down.
Down towards the neck.
Yeah. As the pressure builds, the brain literally begins to crush its own blood supply, starving itself of oxygen.
Oh, wow.
And if the pressure continues, it eventually forces the brainstem down through the foramen magnum.
Which is that opening at the base of the skull, right?
Yes. That process is called herniation, and it is universally fatal if not rapidly reversed.
That is terrifying. So knowing why that swelling is a life or death emergency, let's look at the specific types of bleeds that take up space in that rigid box.
Because they present completely differently when you're standing at the bedside.
Right. Let's start with the epidural hematoma.
So an epidural hematoma is typically an arterial bleed. It often involves the middle meningeal artery tearing, usually due to a temporal bone fracture.
And because arteries are under high systemic pressure, This bleeds very fast.
Incredibly fast.
This leads to that classic, really scary presentation called the lucid interval.
Yes, the lucid interval is a huge red flag.
The patient takes a hit to the head and gets knocked out. A few minutes later, they wake up, they're talking, they seem perfectly fine. Maybe they just complain of, like, a mild headache.
Right, they seem totally stable.
But meanwhile, that arterial blood is rapidly filling the space between the skull and the dura. And then, just out of nowhere, they rapidly decline into a deep coma.
It's one of the most frightening things to witness in an emergency setting because the transition from alert to comatose is so abrupt.
I can imagine.
We contrast that with a subdural hematoma, which is a venous leak. Veins are under much lower pressure than arteries, so the bleeding is a lot slower.
I know older adults and patients with a history of chronic alcoholism are at a much higher risk for subdural bleeds. Is that simply because those populations tend to fall more often?
Well, falls certainly initiate the trauma, but the real reason comes down to the bedside physiology of those specific patients.
What do you mean?
In both older adults and individuals with chronic alcohol use, the brain tends to undergo atrophy, meaning it physically shrinks over time.
Oh, so it's literally smaller.
Yeah, exactly. Because the brain is smaller, there's extra unoccupied space inside the skull.
Oh, I see.
So when they fall, the brain gets jarred around much more easily inside that extra space, which tears the fragile bridging vans.
So because they have that extra space, it creates this highly dangerous illusion of safety.
Exactly. The vault is slowly filling up with venous blood, but the brain has room to accommodate it at first.
Wow, so they might seem neurologically intact for days or sometimes even weeks?
Yes, until they eventually hit a tipping point.
Right.
Once that blood exhausts the last millimeter empty space, the compensatory mechanisms fail, the pressure spikes exponentially, and they crash.
That is so sneaky. We also monitor closely for contusions, which are essentially bruises on the brain tissue.
Yeah, and the evidence tells us that an initial CT scan might show just a small, relatively harmless-looking bleed.
But these contusions can blossom, right?
Exactly. They expand and swell rapidly over the next few hours or days. This is exactly why we do not rely on just one CT scan.
We perform repeat CT scans to catch that blossoming early.
Yes, always repeat the scans.
So because subdurals are so sneaky and epidurals are so incredibly fast, we clearly cannot wait for the classic late-stage textbook signs of brain damage.
No, by then it's often too late.
Right. We have to catch the subtle early clues of increased intracranial pressure, or ICP. What should a nurse actually be looking for when they walk into the room?
What we know from practice is that the earliest signs of increased ICP do not look like profound neurological deficits.
They don't.
No, they look behavioral.
Oh, interesting.
Yeah. You need to be hypervigilant for restlessness, unexplained agitation, any altered level of consciousness, and a constant worsening headache.
So a patient who is sitting quietly and suddenly starts pulling at their IV lines and acting cranky, that's them showing you early signs of cerebral hypoxia.
Exactly. It's not just a bad mood. There's also another massive clinical pearl here, the vomiting red flag.
Right. A head trauma patient suddenly vomiting without any prior nausea.
Yes. It feels like the physical swelling of the brain pushes down and hits a vomit button directly in the medulla.
Because there's zero GI involvement.
None. They don't feel sick to their stomach. They just suddenly throw up.
So if you see that their pressure is spiking,
It's a critical warning sign.
what happens if we miss those early behavioral clues and we ignore the vomiting by assuming it's just a stomach bug?
Then the patient rapidly enters the danger zone. We start seeing the late signs.
Right, the scary stuff.
Yeah. As the brain swells downward, it physically compresses the third cranial nerve, the oculomotor nerve.
What does that compression actually look like when you check their eyes?
That is when the pupils blow. Normally, pupils are small and reactive to light,
Yeah.
Under that intense pressure, they dilate wide open around 8 millimeters and become completely fixed and non-reactive.
Wow. And you'll also start to see abnormal posturing at that point, right?
Yes. Decorticate posturing is when the patient's arms flex tightly inward to their core.
Almost like they are protecting their chest.
Exactly. This indicates severe damage to the cerebral hemispheres.
I know decerebrate posturing is even worse. What is the physical difference at the bedside?
In decerebrate posturing, the arms extend rigidly outward. That tells you the damage has progressed deeper, reaching down into the brainstem.
Oh, man.
You might also assess the Babinski reflex. If you stroke the bottom of the foot and the toes fan out, that's perfectly normal in an infant.
But in an adult?
In an adult, a positive Babinski is a glaring sign of brainstem herniation.
Okay. Then we reach Cushing's triad. This is a late life-threatening reflex indicating extreme intracranial pressure.
Yes, it's very late and very dangerous.
It consists of severe systolic hypertension with a widening pulse pressure, profound bradycardia, and irregular respirations.
Correct.
But wait, if the blood pressure is skyrocketing, why is the heart rate dropping? Normally, if a patient is crashing or stressed, their heart rate shoots up to compensate. A dropping heart rate feels completely backward.
It does seem backward, but it comes down to the ischemic response.
Okay, break that down for me.
So the pressure inside the skull is so overwhelmingly high that arterial blood physically cannot push its way in. The brain is literally starving for oxygen.
So the brain panics.
Exactly. It sends a panic signal to the sympathetic nervous system to massively clamp down all the blood vessels in the body.
Oh, to blast systemic blood pressure sky high so it can force blood up into the head.
You got it. And the profound bradycardia is actually a reflex to that massive blood pressure spike.
How so?
The baroreceptors in the body detect this dangerously high systemic pressure and trigger the parasympathetic nervous system to drop the heart rate, attempting to protect the heart.
So the brain is basically fighting the rest of the body for survival.
That's exactly what's happening.
To catch those early behavioral signs and track the progression before Cushing's triad ever hits, the bedside neuroexam is a nurse's best tool.
Absolutely.
Let's talk about the Glasgow Coma Scale, the GCS. It's easy to memorize the categories: eye-opening, verbal response, motor response. But how do we actually apply this in real life?
Well, the GCS is a standardized tool to objectively measure a patient's level of consciousness. The highest score is 15, meaning fully alert and oriented.
And the lowest is 3, indicating a deep coma.
Right. Let's look at the motor response, which is scored up to 6 points. It's not just like, can they move?
Right. It's more specific than that.
Exactly. A score of 6 means they obey commands. If you ask them to hold up 2 fingers, they do it.
And if they don't obey,
Then you apply a painful stimulus. If they reach across their body to stop you, they're localizing pain, which is a 5.
okay.
If they just pull away from the pain, that is withdrawal, which gives them a 4.
Got it. I remember learning the golden ICU rule for the GCS. Less than 8, intubate.
Yes, that is a crucial rule.
Meaning if their score drops to 8 or below, they are completely losing their protective reflexes, they can no longer protect their airway, and you need to prepare for immediate intubation.
Exactly. And alongside the GCS, there are other physical clues you should be looking for on the head or face during that initial exam.
Like what?
You need to assess for cerebrospinal fluid leaks, which indicate a basilar skull fracture.
Because those fractures occur at the base of the skull and can tear the meninges, right?
Yeah, allowing CSF to leak out. You're looking for rhinorrhea, which is clear fluid leaking from the nose, or otorrhea, which is fluid leaking from the ears.
You never want to just assume it's a runny nose. I know there's specific ways to test that fluid at the bedside.
You can ask the patient if they have a constant salty taste in the back of their throat.
Oh, that's a good one.
Yeah, and you could also drop some of the leaking fluid on a gauze pad. If it is CSF mixed with blood, it forms a halo sign.
Which is like a yellow ring around a central blood spot.
Exactly. You also look for battle sign, which is dark bruising right behind the ear, or raccoon eyes, which is heavy bruising around both eyes.
What if I see a patient with huge blown pupils and a sky-high blood pressure, but they just got out of an eye doctor appointment or they have illicit drugs in their system? How do you factor that into the neuro exam?
That highlights a fundamental reality of bedside nursing. Always checking for masking factors.
Right. Treat the patient in front of you, but get the full history.
You have to. Illicit drugs like cocaine will drastically elevate blood pressure and dilate pupils.
And severe alcohol intoxication can depress the GCS and completely mimic brain damage?
Yes. You always have to evaluate the physical signs in the context of the whole patient.
Okay, moving into the action phase. You've done your assessment. You recognized an ICT spike or a TBI. What are the immediate bedside nursing interventions and what provider orders are coming down the pipeline?
First and foremost is positioning and airway management. You must keep the head of bed elevated to exactly 30 degrees.
To use gravity to promote venous drainage out of the head? Right.
Exactly. That lowers the pressure. You also must ensure their neck remains perfectly midline.
Why is the midline part so important?
If the neck is turned to the side, it literally kinks the jugular veins, trapping blood in the head and driving up the ICP.
Oh, wow. We also have to prevent the patient from doing anything that increases intrathoracic pressure because that pressure shoots straight up into the brain.
Right, so we have to strictly avoid letting them strain.
That means no extreme flexion of their hips or knees, no coughing, no blowing their nose, and absolutely no bearing down.
Which is why we anticipate giving stool softeners, so they don't strain during a bowel movement.
Makes sense. Now, I know airway clearance is critical, but it requires extreme caution.
Very extreme caution.
Wait, if they have a compromised airway or they're pooling secretions, shouldn't we suction them thoroughly to keep the airway clear?
We must keep the airway clear. But the evidence tells us that the physical act of suctioning dramatically spikes intracranial pressure.
Because it stimulates the gag and cough reflexes.
Exactly. If you absolutely must suction a TBI patient to clear an obstruction, you must limit the suctioning pass to less than 10 seconds.
And you must hyperoxygenate the patient with 100% oxygen before you do it to protect against hypoxia, right?
Yes, always hyperoxygenate first.
As for anticipated provider orders, the absolute first line of action is getting a stat non-contrast CT scan of the head.
Right, so we can actually see the physical bleed and quantify the swelling.
Medically, how are we reducing that cerebral edema once it's confirmed?
The primary medical goal is pulling fluid out of the brain tissue. We anticipate administering mannitol.
Which is an osmotic diuretic.
Yeah, it doesn't just make the kidneys excrete water. It works by altering the concentration gradient in the blood.
So it makes the blood hypertonic.
Exactly. That physically pulls water out of the swollen waterlogged neurons and into the vascular space, where it can then be excreted by the kidneys.
That is so cool. We also look for orders for corticosteroids, specifically dexamethasone, right?
Yes, which is powerful at reducing inflammatory tissue edema.
And we anticipate giving anticonvulsants like levetiracetam, commonly known as Keppra.
Right, because as those neurons get swollen and compressed, they suffer from cortical electrical instability, which causes seizures.
And a seizure in a TBI patient is a disaster.
A total disaster, because it massively increases the brain's metabolic demand for oxygen when it's already starving.
Wow. And it goes without saying, blood thinners like aspirin are strictly avoided.
Strictly avoided.
Okay, so if our interventions are successful, the patient stabilizes, and they are preparing to transition home. At this point, our nursing role shifts heavily toward education.
Yes, we have to prepare the patient and their family for the long-term realities of a TBI.
Which is often called the invisible disability.
Exactly. A TBI survivor might look perfectly fine on the outside. They don't have a cast. They don't have a visible wound.
Because of that, family members and friends often dismiss their ongoing symptoms or just get frustrated with them.
Yeah, we have to validate for them that clinical evidence clearly shows that concussions are traumatic brain injuries. They're not just getting your bell rung.
Right. We must proactively prepare them for the personality changes that families will likely report.
Yes. Following a TBI, families often note sudden mood swings, uncharacteristic irritability, or just a noticeably shorter fuse.
They might also see changes in how the patient expresses themselves, like their speech speed or facial expressions.
And it's so important to remind families that these are not intentional behavioral choices. They are the direct result of neurological damage.
It is crucial to explain that so families offer grace instead of getting angry.
Absolutely. For discharge teaching, we remind patients to avoid driving or operating heavy machinery immediately, as their reaction times and processing are impaired.
And we give them strict return precautions.
Very strict. We emphasize that if they experience worsening dizziness, returning nausea, or any subtle change in their level of consciousness, they must return for emergency care immediately.
Because that could be a slow venous subdural bleed finally hitting its tipping point weeks later.
Exactly. You can never be too careful.
To summarize today's discussion, managing TBIs is fundamentally about managing space and pressure. As a nurse, you are the first line of defense.
You really are. You must catch the early behavioral changes, the restlessness and agitation, long before the physical posturing and Cushing's triad begin.
And you must use your bedside positioning, keeping that head of the bed at 30 degrees and the neck perfectly midline, to actively protect the brain.
Trust your gut when a patient seems off.
Right. If a patient with a head bump suddenly gets inexplicably cranky, or they vomit without feeling sick to their stomach, you must act immediately.
You are seeing pressure building in a rigid box, not a stomach bug.
Such a great point. Don't forget to watch the video on YouTube, like, subscribe, and leave a comment.
And please visit supernurse.ai for great resources to help you become the super nurse you were born to be.
Keep asking exactly why things happen at the bedside. Because when you understand the mechanics of that tightly packed suitcase, you will never look at a cranky post-fall patient the same way again. Stay curious, everyone.